I can't see Janice. All right, good morning, everyone. No, actually, good afternoon, everyone. It's after 12 noon. Welcome to today's IE-CHI Quarterly Health Education Forum, Child Mental Health During COVID-19. What have we learned? I'm Alice Nelsner, and I'm the Executive Director of the San Bernardino County Medical Society, and I'm also the chair of the IE-CHI, or the Inland Empire Coverage and Health Initiative, a coalition whose mission it is to ensure that all families and residents have access to affordable, quality, and culturally sensitive health care in the Inland Empire, which includes Riverside County and San Bernardino County. Be sure to look us up on our website at iechi.org, as well as on our Facebook page, IE-CHI at Facebook. As we get started today, I want to welcome our IE-CHI Board and Advisory Council, and I want to do something special for a moment. I want to give a huge congratulations to our Advisory Council member, Dr. Danielle Kelkenstein, who as of last Friday is now a Doctor of Public Health. And I don't know if Danielle's on the call. Is Danielle on the call with us? I'm not sure if she's on or not, but she successfully defended her dissertation through Loma Linda University School of Public Health and earned her degree. So Dr. Kelkenstein, congratulations. And here's a round of applause for you. Woohoo! Yay. All right. Our topic is timely today, not only because May is Mental Health Awareness Month, but also because we are also aware of what our kids and families have been through the past year with the ever-changing rules regarding school protocols and the toll it's taken on our children's mental health. We have our keynote presentation today, followed by our panel presentation with guided questions. So I'm going to start by introducing our keynote presenter. A couple of quick notes. Please be so kind as to keep yourself on mute if you would. And if you have questions, we're going to do a Q&A session after all the presenters have spoken so that everyone has a chance to speak. We'll go ahead and take your questions by the raise hand feature on your Zoom dashboard screen to make things more interactive. Or if you're more comfortable entering your questions in chat, go ahead and enter them that way through while people are speaking. And my colleague with SBCMS, Soteria Cobb, will read your questions aloud at the end of the panel presentations. So normally I would tell you where the restrooms are if we were meeting in person, but I don't think I need to tell you where those are today. Hopefully you know where those are during this presentation. All right, it is my honor to introduce our keynote presenter today. Dr. Veronica A. Kelley, DSW, LCSW, is the director for the San Bernardino County Department of Behavioral Health, and she oversees the daily operations for both mental health and substance use disorder services. Veronica is a member of the governing board for the County Behavioral Health Directors Association of California. Serving as the president-elect, she sits on the executive committee and serves as the co-chair for the Substance Abuse Prevention and Treatment, SAPT, committee. She is also a council member to the California Behavioral Health Planning Council, board member to the California Mental Health Services Authority, and associate member to the American Society of Addiction Medicine. In August of 2019, she was appointed by the governor as a member of the No Place Like Home Program Advisory Committee. Dr. Kelley is a professor at Mount St. Mary's University teaching in the undergraduate social work, sociology, and gerontology and film department, an adjunct faculty in the Master's of Social Work program at Loma Linda University Department of Social Work and Social Ecology, and a contract instructor at Cal State University, San Bernardino, teaching social work with alcohol and drug abuse. She earned her doctorate of social work from Capella University, earned her MSW from the University of Southern California, yay, and her BS in psychology and child development from Mount St. Mary's College in Los Angeles. Welcome, Dr. Kelley.
Thank you so much, Allison, and thank you very much, IECHI, for the opportunity to speak about this super timely topic. And happy Children's Mental Health Awareness Day that's occurring today during Mental Health Awareness Month. You know, the pandemic has reminded the rest of the nation the importance of mental health. And for those of us in the field, we've been very, very busy this past year and a half. Mental health is not just about the most severe outcomes like completed suicides and overdoses. It's about our everyday wellness. And so multiple researchers have reviewed the early stages of the pandemic, and they noted no significant changes in suicide rates overall, but there are certain groups that have been more vulnerable to the effects of the pandemic and have experienced increased rates of suicide. So we know absolutely our elders. Their elders are the leading group to complete suicides, elderly males in particular, but the social disconnection that we've been experiencing along with our quarantine really heightened the loneliness and isolation. Plus, technology literacy has been an issue for some of our elders. The National Child Mortality Database research has shown that youth may have had an increase during the earlier phases of the lockdown due to disruption to education activities and support. And many communities of color saw a slight increase in suicide versus a decrease in them, what we're seeing in the white population. We know what has happened in other disasters, whether those are natural or otherwise. We see a short-term decrease in suicide in the immediate aftermath of a disaster and then an increase later. We saw this locally following our December 2nd terrorist attack. This really is known as the honeymoon or the pulling together phenomenon, and that's achieved when we're all in this together, which we are all in this together, but we tend to go back to business as usual, disconnected and super stressed, and of course, ignoring our mental health. But the pandemic has taught us a great deal. It's taught us about technology, that we need it, that not all of us have it, that lots of us still don't know how to use it, that if you got your free Wi-Fi from the public library or from Starbucks, that you didn't have it when the shutdown occurred. That if you lived remotely, you found out that maybe what you feared to be true was true, that you were unstable, that your internet was unstable. So there were a lot of access issues for folks who were living in the vast areas of our county in particular. We all learned that people of all ages needed help with technology, and that although our kids were proficient in Mario Kart and in Minecraft, they were not able to pay attention for great lengths of time in a Zoom lecture or a WebEx. They needed guidance, they needed boundaries and direction from someone who could actually check to see if their camera was on. Interesting, I was discussing this with my compliance officer yesterday. She has 2 elementary school children. And she said they just received a notice about the nude dad incident with regard to Zoom. And a reminder was sent out to all parents to make sure they are wearing clothing in their home when children are in school. So there's that. We learned that overexposure to media via technology can be bad, that our brains cannot take too much activation, especially about negative things. So too much negative information. So think about all the deaths that we've seen due to COVID, even what we're seeing currently in India. We are watching it in real time. That's too much information. We also were impacted by social injustice and deaths from social injustice. All of that increases our overall anxiety. And if you bring to the party a history of trauma, and maybe you haven't addressed your own personal trauma as much as you'd liked, the extra baggage of that past trauma with the current one can lead to a heightened level of anxiety. We learned that blue light impacts our sleep, and prior to technology, we lived mostly in daylight. But the new light from our phones, our computers, and our televisions emit blue wavelengths, and these can be beneficial during daylight since they boost attention and reaction times and mood, but they're very disruptive to us at nighttime, in particular because they throw off our body's natural clock. Remember, we weren't meant to be exposed to blue light for 8 to 10 hours straight, like most of us are. And so our circadian rhythm gets out of whack. And there's some data that shows that that even contributes to more significant health issues. We learned that like our overexposure to news, that overexposure to social media negatively impacts our brains and our emotions. But it was very useful for feeling connected, especially when we couldn't see our family and friends. but it was a balancing act about how much you log in on your social media and how much you don't. And we were reminded that hearing a human voice and seeing a human face are important for us to feel connected. Especially just think about us being here today. When we are faced with a black box that says someone's name on it, it's not the same as when I can look out and see Janice's face or Felix's face. We especially understood the importance of this when a loved one was hospitalized or when a loved one died during the pandemic, whether it was due to COVID or not. We learned a great deal about stress, that some stress is great, it leads us to be motivated, helps us get things done, but that too much or distress can be crippling. We learned the importance of activity, not just that children learn via play and kinesthetics, but that we all need to move. Vigorous activity, it resets, it reboots our brains. Exercise reduces levels of the body's stress hormones like adrenaline and cortisol, and it stimulates the production of endorphins, chemicals in the brain that are the body's natural painkillers and mood elevators. For children and adolescents, moderate and vigorous physical activity and exercise during the day are associated with elevations in self-esteem, improved concentration, reductions in symptoms of depression, and improvements in sleep, as well as overall mental health. So that's another good reason for physical education. We learned that most of us have adequate coping skills for stress, but that the majority of us really need some help in developing better coping skills. We saw an increase in the use of eating, drinking, and drugging as coping mechanisms, and our kids learned those same behaviors from us. We learned that resiliency doesn't necessarily mean we're superhuman. It means we're survivors, but even survivors need to address our stress. We saw in San Bernardino County an increase in calls to our helplines during the past year and a half. So Dee Hirsch is a contract provider who receives some of our mental health crisis calls. And in February of 2019, the average call volume was 21 calls. That was pretty much the average we had seen in the months prior. But in March of 2020, we saw that 21 calls go to 1,800 calls. And then in April, it went to 3,300 calls, and it's been about that volume since then. We also held a WebEx for county employees. We had one day to have folks register for it. They had to do it during the work time. We actually scheduled it during lunch. And we had 638 county employees jump on because they wanted to learn what to do with their stress levels. And it led to a discovery of many types of serious stress. I had folks reach out to me from that event, a high-level first responder who was suicidal in that moment, who we actually sent a crisis team out to get him into a hospital voluntarily. We had a number of folks, all women, who stated that they couldn't telecommute, which was what the county went to. They couldn't telecommute because it was dangerous for them to be at home because of domestic violence. And so we had to work with their supervisors to figure out how we could get them safely into the workplace. And a few of those worked for law enforcement. We learned that mental health and substance use disorder are possibilities for all of us, for our kids as well. And that like our physical health, if we don't take care of our mental health, we are going to get sick. We learned that we have to address injustice if we want to be well, because racism makes us sick. Although rates of mental illness in some communities of culture and color are sometimes comparable or even slightly lower than rates in the white population, communities of color often experience a disproportionately high burden of disability from mental illness. Black adults are 20% more likely to report serious psychological distress than adult whites. And although rates of depression are somewhat lower in our Black and Latinx populations than in our white population, depression in Blacks and Latinx people is likely to be more persistent and more profound. People who identify as being two or more races are more likely to report mental illness more likely than any other ethnic group within the past year. And Native and Indigenous people report higher rates of post-traumatic stress disorder and alcohol dependence than any other ethnic and racial group. We know that mental and behavioral health conditions are common among people in the criminal justice system, in which communities of color are disproportionately overrepresented. Approximately 50 to 75% of the youth in our juvenile justice system meet the diagnostic criteria for a mental illness. Cultural incompetence and inequity of our healthcare providers likely contribute to the underdiagnosing or the misdiagnosing of mental illness in communities of color and culture. Language differences between the patient and the provider, stigma of mental illness, and the cultural presentation of symptoms are some of the ways that these barriers to care can be explained, as well as our errors in our diagnostic process. And so we have to do better than this. One study found that physicians were 23% more verbally dominant and engaged in 33% less patient-centered communication with Black patients than white patients. And compare with white people with the same symptoms, Black people are more frequently misdiagnosed with schizophrenia and less frequently diagnosed with mood disorders. Native and Indigenous American adults have the highest reported rate of mental illness of any single race identifying group. We know that racism and its impacts on mental health are serious. They're serious for us, but they're very serious for our children, such that the American Academy of Pediatrics came out in September of 2019 with its statement on racism and children's health, noting that racism is a social determinant of health that has profound impact on the health status of our children, our adolescents, emerging adults, and our families. And although progress has been made towards racial equality and, more importantly, equity, the evidence to support the continued negative impact of racism on health and well-being through implicit bias, explicit biases, institutional structures, and interpersonal relationships is very clear. The objective of their policy statement was to provide an evidence-based document focused on the role of racism in child and adolescent development and health outcomes by acknowledging the role of racism in children and adolescents. Pediatricians and other pediatric health professionals need to be able to proactively engage, as well as teachers, in strategies to optimize clinical care, workforce development, education, systems engagement, and research. Our world saw a reckoning on racism this past year, reminiscent of the civil rights movement, and it has impacts on our children's mental health, not just now, but into the future as well. That, coupled with the first pandemic, COVID-19, has made things very difficult for us. But we have certainly learned a lot in this past year, and hopefully we remember some of those things so that we do not repeat the errors of our past. Thank you.
That was fantastic. Thank you. That was very powerful as well. Thank you, Dr. Kelley. That was wonderful. Appreciate that. All right, I'm now going to introduce my fellow IECHI board member and my friend, Alexander Bravo, who will be facilitating the panel presentation today. Alex Bravo has served as the Community Engagement Manager at Molina Healthcare of California for more than 13 years. Since 1985, Molina's mission has been to provide quality health care to people receiving government assistance. In California, Molina serves their members through government programs such as Medi-Cal, Medicare, and Covered California Marketplace. Alex is responsible for leading the company's community efforts and partnerships in the Inland Empire and Imperial County, in which she uses her extensive knowledge of healthcare and her genuine passion for helping those less fortunate. In her current role, she plans and directs the department's budget, manages the community engagement team, organizes quarterly community advisory council meetings, and coordinates community events and conferences throughout the year. She's played a pivotal role in putting on Molina Healthcare's annual Community Champions Awards, an event that honors local residents who go above and beyond through community service. Additionally, Alex and her team executes the Molina Hope Diaper Drive, which garnered more than 40,000 adult briefs and baby diapers for vulnerable populations in local communities, something we're proud to participate in as well. And of course, Alex is very active on the IECHI board. So Alex, I will turn it over to you at this point.
Fantastic. Thank you, everyone. And thank you for the very warm welcome. I have the privilege and the honor of facilitating the panel discussion. We have a very robust panel for you, and I'd like to introduce each of our panelists. First, we have Mr. Felix Perez with Riverside County Office of Education. He's the Program Development Specialist focusing on mental health. He has been with the Head Start program for over 6 years, and he holds a bachelor's degree in social work from California State University, Los Angeles, and a master's in science and social work from the University of Louisville. Prior to his current position in Head Start, Felix worked 2 years in Los Angeles County for gang reduction and youth development for over 20 years. He also worked for Orange County Healthcare Agency as the outpatient mental health clinic, drug court domestic violence, and substance abuse court, and as a mental health clinician in Orange County. Felix has worked collaboratively with the Head Start management team to establish monitoring guidelines to ensure program compliance. He monitors 11 delegate agencies and 17 direct operated sites for Riverside County Office of Education in the area of mental health. One of his goals is that our neediest families and children build resilience to overcome many obstacles and achieve potentials that will last a lifetime. When not in the office, he enjoys family, golfing, fishing, cycling, football, baseball, travel, eating, and the outdoors. Felix, I don't know how you have any spare time with everything that you're doing, but welcome. Next, I'd like to introduce the next panelist, Miss Arlene Molina. She's the Deputy Director of Program Operations with San Bernardino County Preschool Services Department. She's been with the county for 2 years and has previously supported early learning programs that include services to students, military, and community families. She currently oversees planning and delivery of mental health services to all preschool service department, enrolled children, and families. Preschool services department serves approximately 6,000 children per year in 5 distinct programs. Welcome. And last, but certainly not least, we have Beatrice Blake. She is with San Bernardino County Superintendent of Schools and part of the Reaching the Whole Child program. She's the coordinator since September 2019. Beatrice oversees the tobacco use prevention education county programs and mental health supports in partnership with the Department of Behavioral Health. Beatrice is a veteran educator, having spent 14 years in the classroom as a science teacher and 4 years as a school site administrator before joining the Healthy San Bernardino County Superintendent of Schools team. She holds a bachelor's degree in science with an emphasis on health education and a master's degree in educational leadership. Welcome to each of our panelists. And what we have is a series of questions that are prepared for our panelists. We do have a limited amount of time. What I'm going to do is I'm going to pose these questions to our panelists, and we are going to specifically ask that each of our panelists answer a question. They'll have an opportunity to chime in, but it's a very robust panel and some great questions. So the first question I'm going to pose to Felix, and it's a 2-part question. Felix, what are the major mental health challenges with virtual learning? That's part A of the question. And part B is, what mental health support changes were made which will remain after on-site learning resumes, and why?
Thank you, Alex, for that great introduction. And you're right. You asked how I make time to take care of everything. I do it by sections. I can't do it all at the same time, but I do the best I can to make it all and fit everything in. Again, as Dr. Kelley mentioned, we have to take care of ourselves so that we can be able to provide for everybody else. So to answer the question, I'm going to speak on behalf of the RCOE Head Start information gathered. What we found is, prior to the COVID period, our clinicians were able to access classroom 5 days a week, on average 6 hours per day. So it allowed for them to transition from classroom to classroom, work with the children on a one-on-one basis, provide all these support groups as well, provide trainings. And when COVID hit, they weren't able, or they didn't give us enough time to have them take material home. So during this time, a lot of clinicians felt that they needed, they lacked social emotional supplies in their home to make sure that the children got the required services that they needed. Secondly, because we hire outside consultants as well as through district consultants as well, not having the proper equipment that allowed them to actually link to the classroom sites. Sometimes the different emails account wouldn't allow them to actually join classrooms. The teachers weren't really sure if they were logging in to the right places. I think Dr. Kelley mentioned some, what are they called, those hackers that were just bombing classrooms. So they were hesitant to allow mental health consultants to join their classroom to do observations and provide support. And again, that came with time. Once they felt comfortable, the clinicians and the instructional staff communicated well, and you could see an improvement on child's life. The limited time allowed also because they were focusing how Riverside Early Learning Service started off. They went to an hour per class, you could say. So it went, again, as I mentioned earlier, we went from 5 days a week, 6 hours per day on average, to 1 day a week, and trying to fit one clinician to see 20, 30 children was almost impossible. So they went from seeing them on a regular basis to maybe once or 2 times a month. At that point, parents were becoming a little bit frustrated to the point where they weren't seeing that actual growth on the children with their participation. They also found that due to their attention span, they weren't really focused on the mental health portion or the academic portion. So they were just falling, logging out, having issues just connecting with the system in general. The physical, what they also indicated and reported as well is the lack of the physical interaction with other children. And this is later in the program. When we went back, we noticed that the children were having less time with the children, the fear, not knowing how to engage, not knowing what limits, what boundaries, how to be safe. And I think that's something that we definitely learned for next program year, depending on how we return to the classroom, on making sure that we review, practice, and make sure that these children are well prepared to return to the classroom. What we're doing here in our program, we're having a summer program where we are going to have the older kids transition into kindergarten, and that's going to be our focus, making sure that they're aware of the school guidelines, what limits, and additional supportive services that they can definitely benefit from, so that they can transition into kindergarten. We noticed as well, the clinicians had a hard time managing their own home environment and also transitioning and working with the children as well. So we had some clinicians that had young children, so they had to manage and set schedules for their children and plan ahead so that they can work with their clients or consumers. So that was another challenge that we had there. But eventually, again, as we moved and the clinicians were able to get a consistent schedule, they found this to be effective. Parent participation and the number of parents that were undiagnosed depressed, as Dr. Kelley mentioned briefly, that we did have a lot of consumers that parents did have challenges of their whole mental well-being. And they really lacked the support, the participation, the social engagement with the children and managing, depending if they had siblings of different age groups. So we found that they lacked the ongoing support on a consistent basis. We had some parents that actually said, I'm not a teacher, I don't know how to do this. So there was also that challenge, making sure that our instructional staff supported the parents our family engagement workers actually assisted the families to make sure that they attended um, webinars, attended classes, attended just ongoing support groups to make sure that we can support them as much as possible and provide the actual resources available to the family. I think devices are early in the program year for early learning. Their emphasis was K through 12, I believe, in getting devices to the children. So when we inquired on getting devices, it was very challenging. It was a worldwide epidemic, so getting computers to our children was delayed. So our teachers had to become innovative. We provided hard copies materials. They had difficulty, as we all know, just getting materials in general, from making copies, paper. We were limited with resources, but we managed to do that until computers came up to get services. And that's pretty much as much as information that I have. Can the team share anything else, please?
Felix,
Thank you,
that
Felix.
was, oh, yeah, if I could just add to what you just shared, and your list was extensive. Thank you for covering basically all the bases. I would be remiss if I didn't go to the very beginning of the experience, in that what started as a 6-week, 3-week, a shutdown turned into a year-long experience for all of us, and I would say at that a traumatic experience. We are each having to deal with individual experiences, and then as educators, we are then taking on the experience and the trauma that our students bring to our classrooms on a regular basis. So I just wanted to acknowledge that, because we began this journey and this experience with uncertainty. We really didn't know what was going to happen and how long it was going to last. And so initially there was, I would say there was interruption in learning, standards-based learning, that was as a result of really not knowing what and how long this was going to take. And then in pivoting to a full learning environment, some schools decided to focus on attendance, and others decided to embrace the full learning experience. And so it's really hard to encapsulate one response to these questions, because for example, in our county, overseeing 33 different districts, there is not a cookie cutter approach to the educational system. We have to respect the individual implementation of the LEAs within our county, including charter schools as well, and non-public non-traditional schools as well. But I will tell you that the mental health providers, especially our prevention and intervention staff members working closely with the Department of Behavioral Health, pivoted quickly. I was actually working with the Department of Behavioral Health, with Dr. Haugen specifically, in connecting with the districts and making sure that we had the information available and accessible to all of our districts that were being supported by the prevention and intervention teams through the student assistance programs. And it wasn't easy. Communication was challenging, because the primary focus of the districts and the LEAs was really to pivot essentially overnight. With the blink of an eye, they had to pivot their full educational implementation to a virtual space, which if you would have asked a week prior or a month prior if that were possible, everybody would have said, no way, that it is not possible. And so I think that we definitely overcame some pretty phenomenal challenges, and what's going to continue in our return back to in-person educational settings, or some kind of hybrid models, is we're going to continue what has worked. And what has worked is that we've been able to pivot therapy sessions through the telehealth, ensuring HIPAA and FERPA mandates to ensure student confidentiality. We are now able to connect with some families that perhaps might have had some barriers to accessing schools due to transportation or due to working schedules. So there are a lot of good things have actually come out of this very challenging experience for us in education. I do want to highlight the importance of the relationships that have been reinforced through this process, and specifically the relationships centered around mental health supports with the Department of Behavioral Health in our respective counties, and the community partners that have come to the table and have been at the ready to make sure that schools have everything available and accessible to them, so that our students and our families and our communities, especially in our neediest of communities, have the resources necessary. And realistically speaking, the beginning of this experience was very much focused on nutrition. Did our families and our students, did they have access to food, the basic resources? So I think that it's been a long journey, and as teachers prepare to return to in-person education in the fall, all of these things are going to be resurfaced, and for the first time perhaps in education, everyone's on a level playing field, and that we've experienced this together, we've been through this trauma together. And so it's no longer I, the educator, and you are the student, you have to listen to me, or have these shared experiences that have united us, and it's going to take us into this into the future. Not to mention, we've seen so much resilience. So thank you for the opportunity to share on this topic.
I think that the one thing maybe PSD has to add to that, or maybe to reinforce what's already been said, was that our major mental health challenges were that families didn't have what they needed to survive. So not even talking about thriving, they didn't have food. At that point, San Bernardino, at the beginning of the pandemic, had moved completely to the WIC cards. So we had families who had to get 6 cans of WIC, but there was a 1 can limit. So what do you do when you are essentially, it's being denied part of your food that you need to feed your babies? They couldn't find diapers, they couldn't find wipes. So as our behavioral interventionists reached out, hey, do you need support? Do you need services? And they said, we need food and diapers. So our first order of business was to make those connections within the county, make those connections within the community, to even enable our participants to say, okay, now we have food. We'd like to talk to someone because we're scared. So all of those things, like we only had a 1-day gap in meal service for our programs, because we were able to meet with our vendor, access food early on. We were able to partner with another department within the county to get food boxes delivered to our families, formula delivered to our families. We worked with CAP to get diapers and clothing and the things that they couldn't get, they couldn't leave the house to get, and things that weren't at the market at the time. And as we processed through, the other thing that we really focused on was teacher wellness. Because as Beatrice said, absolutely, we were all going through this pandemic together. So our teachers and our support service workers and our clinicians were called on to help families, and they were going through the same challenges as the families. So we had a real significant focus on staff wellness. And I think that those two things, I mean, we had the same challenges with confidentiality and telehealth consent agreements and having to go through that and send it through county council and getting all those things in place. But now that those things are in place, we are in a position to be able to continue some of those distance services. For example, we returned to school for about 30% of our children last month, April 5th. So we're still continuing to do some of our groups online for the families who can't come back, or who, because we have cohorts and we can't mix classes, you know, all those children are able to, after school, have their parents participate in our groups, our trauma groups and our grief and loss groups and our one-on-one or parent support groups. So that's something that can stay because we have all of the pieces in place now. And I think the other thing that will remain is that we have a heightened sense of awareness of what it looks like when we need support. And we have a heightened sense of awareness of asking families, how can we support? So I think that those are the components that will stay, that will actually help us to be responsive to families, because those things like Beatrice mentioned, those transportation issues, right? We actually had a significant increase in completed visits because a lot of the times the visits were canceled because they didn't have transportation, they missed a bus. Someone was supposed to watch their kids and then they backed out at the last minute. So our parents are showing up for their meetings and for their support team meetings for their children. So I think at PSD, as we move forward, we're considering both the wellness for our families and how to ask. There were questions before that we were afraid to ask because it felt like it was invasive. And parents were afraid to answer because they thought their children were going to be removed. If I say, I don't have enough food in my house, are you going to take my kids? And so now we have built those relationships and we've worked on those processes of asking questions respectfully and following through with providing support to build that trust. So it's my hope and honest belief that PSD will move forward with all of those increased sensitivities and increased access, honestly, for families to mental health services.
Thank you very much. It's definitely a heavy lift to see where we were, where we're going, and where we're at. So a big thank you to each of you for everything that you're doing, not just for our children, but the families in the Inland Empire. The next question that I have is for Arlene. And the question is, how is county schools and school districts developing more systems and technological resources for addressing mental health issues for children, families, and teachers?
I think at PSD, one of the things that we really looked at was we did an analysis of what we needed to be successful technologically and where we were at. And so we really looked at what were the easiest pieces to get completed. So for us, hardware was the easiest thing, right? We had relationships with different vendors where we could get equipment turned around very rapidly. We had relationships with different app developers and that sort of thing. So we used 3 different apps to support parents and families, and we went to them almost immediately and said, this is what we need for distance learning. What can you do for us? So once those things were in place, we secured more hardware for parents. We distributed the laptops and tablets and hotspots. We were able to focus on training. So we worked with the developers. We said, this is what we need. With one app, they incorporated our Head Start Early Learning Foundations. With another app, they incorporated online assessment that parents could contribute, and so could staff. So we had kind of a collaborative assessment for children. With another app, we were able to work with them on things like supporting literacy and STEM development in children. That was our Footsteps to Brilliant app, and it was part of the Vision to Succeed, I believe, for the county. And so we reached out almost immediately, had these modifications to the app that these developers were able to complete for us. And then we worked on training. We trained staff on how to use the different apps effectively, how to individualize curriculum for children in the app, how to individualize curriculum for the classroom. In their Zoom sessions. We had Zoom trainings for teachers. We had trainings for parents on what to look for in an observation for an assessment, how to enter those assessments in the app. So I think that our process was A, get hardware out, B, get training completed, and then we were able to follow up and check in on how things were going. So once the foundation was laid, it was really a process of having our family service staff and having our teaching staff and having our tech staff communicate with families and then communicate with each other. And so I think that that kept us connected to parents because we were able to look at the observations that parents entered into the app and say, wow, 3 weeks ago, we were seeing 1 or 2 tantrums a day with the child, and now we're seeing 5 or 6. Does your family need support? And then we were able to connect them with those clinicians rapidly. We were able to look and see that parents weren't logging in not only to their Zooms, but they weren't logging into their any of the apps to do work either, because teachers had access now to the back end to see how often children engaged with the different apps. And so we were able to reach out to those families to go and do home visits and drop the door hangers to tell them, hey, we're here, you know, we want to know why you're not accessing, and we want to be able to support you. And so because of that, we were really able to catch a lot of those issues earlier, right? A lot of the things that were starting to become concerns for parents, and address them much earlier than if we hadn't really enhanced our technology.
Thank you. Beatrice, Felix, anything that you'd like to add? All right, on that note, we'll move on to question number 3, which will be for Beatrice. And that question is, how are schools and school districts engaging our children and youth in managing their own mental health?
Thank you for that, Alex. And I do have a just a comment on the prior questions and a question, and then I will answer the next. So regarding technological resources, our county Office of Education, as well as Riverside County Office of Education and counties across the state of California, there has been a priority focus in improving the instructional delivery of curriculum through distance learning. And so through our dedicated teams, what we have invested in, it wouldn't be an exaggeration to say that it was 24/7. It was literally around the clock webinars, professional development opportunities for districts across the county to engage in learning how to fully pivot to distance learning in essentially overnight. So for some teachers, that was an easy transition because they were already vetted and had embraced the technology. But really, for a big percentage of educators, that wasn't the case. And so it was through these extensive supports from the County Office of Education where it was not only content driven, but in order to be able to deliver the content, the educators really had to capture the attention. So how do we do that? We want educators had to pivot to engaging students through the virtual space, which could pose a challenge. And at first, if you're not comfortable with technology, obviously that's going to be an uncomfortable transition for the educator. And so, you have the educator experiencing growing pains and just really having to pivot everything that they do. And so it was through relentless training offerings and really embracing the resources that are available across the state through Q trainings, educators. We have an increase in teachers trained in our Google certified. They implement just the various apps to engage students in content learning, but before they're able to do that, what we also noticed and learned and really promoted from the County Office of Education was an emphasis on connecting, making a deliberate intention and connecting with the students and really checking in to see how they're doing, whether it was on camera or off camera through the chat function. Teachers really took the time to check in with the students and really foster that social and emotional piece of relationship and connectivity with our students. And continuing with the addressing the mental health issues in the county, there has been an emphasis on suicide prevention. And so if you're in the world of suicide prevention, you know that suicide prevention is it's a continuum. So we may have we may be in post crisis, or we just experienced a loss, and then so we're going to re-examine our systems of implementation and really start at the prevention piece again. And so there's been a high emphasis in offering suicide prevention trainings for educators to really identify early signs and symptoms of mental health challenges in students. And so taking it back to the classroom, if you have a teacher who is been recently trained in suicide prevention and is able to identify early signs or symptoms of a mental health crisis or challenge or concern, and they're able to link it to their site level counseling staff or administrators, who are then able to then continue the connection to the providers within their respective organizations. And so that has been has been at the forefront of everything that we do in public education. And again, going back to the beginning, there was slight interruption because we thought we were just going to be in this for 3 weeks, 6 weeks, and then and it was full force transition. And it really did start with the mental health providers in schools and the counseling staff, the psychologists, the social workers, who said, I need to see my students. I haven't been able to check in with them. I haven't been able to connect with them. I really need to touch base. And so out of that, really just evolved the continuum was disrupted. There was a decrease in accessing students for mental health related services, and now we're seeing an increase. So now transitioning to how schools and districts are engaging children and youth in managing their own mental health. Prior to COVID, there is high emphasis on MTSS and PBIS responses to really guiding students in behavior and intervention approaches on school campuses. And so with the transition to full distance learning, there's been a pivot and high emphasis on social emotional learning. And with that comes mindfulness. And so I think that I could probably say this without having to take my words back, but probably the 33 districts in San Bernardino County have SEL as their primary focus in preparing both students and staff to return back to in-person learning. And how do we model and implement SEL? We have to start with the educator. We have to start with the practitioner. So if we are supported and we are practicing these approaches to well-being on a regular, daily, and classroom by classroom basis, then our students are going to, one, have a model, and two, they're going to have the safe space to enter and say, you know what, it is okay to be in this classroom even though I'm not okay. And this is how it is okay, because my teacher has, one, taught me some self-regulating practices, and two, has given me the links and the options of choice. When I am not okay, this is how I can approach and ask for permission to go to a space where I can get the support, immediate support that I need. And so some kind of version of that. Again, there is no one cookie cutter approach to any of these implementations. We do have to honor and respect the individuality of, one, the teacher, the site level systems and protocols of a school, the leadership of a district, and their administrative and board regulated supports. And so the problem is not that there is a lack of resources, because there isn't. I think that really this boils down to is the ability of leadership in school districts, and of course with county schools or county offices of education and community partners at the table, really sharing resources through a collaborative approach. We call that collective impact, where we come together and we say, this is what this is working for us, and let me share with you what our success is, so that we can really expedite the resource finding and narrowing down through the countless resources that are currently available. So just for example, there's a suicide prevention toolkit that's over 200 pages. There are requests coming in from LEAs in San Bernardino County saying, do you have something that is more straight to the point? Because I genuinely don't have time to go sift through a 200-page document. And so it's really through this collective impact approach where we can bring us together to share what's working and really expedite the next step as we transition back to schools. And so to circle back and answer the question, I think that the collective approach impact with an emphasis on social emotional learning and really focusing on the wellness of the self, kind of the, exhaustive and commonly referred analogy is you're on an airplane and there's an emergency, the oxygen mask, who do you put it on first? Do you put it on your child or do you put it on yourself? So because we are in charge of our students as educators and as leaders, what we want to do is we want to mask up first. We want to make sure that we are in a position where we are equipped with the tools, the knowledge, and the resources necessary to make sure that all of our students and all of our families have access to the resources necessary and immediate connection to community-based school and community-based resources as they need them in real time. Thank you.
Thank you. Arlene, Felix, anything that you would like to add?
I would like to add that at PSD, our kids are really young, right? They age out at about 5. So while we do basic things with them, like, how does your body feel? You look really angry. I see, recognizing those physiological symptoms of emotions. A lot of our focus was working with parents to help them understand those social emotional and those developmental milestones so that we could have, their partnership in advocating for mental health services for children when they're needed. For parents to get the knowledge to identify, what's typical and what maybe we should make a referral for, and for them to be able to recognize their own things in themselves. So we did put a high emphasis on parents being able to identify, to work collaboratively with teachers for requesting service and for even asking questions, like going over our screeners with them and talking about, your child scored in the concern area here, and this is why. And so really preparing them to be able to participate in their child's mental health planning and observation moving forward.
What we did here in Riverside County, we also had a focus on social emotional, and we individualized our lesson plans to go approximately 16 days so we can have everybody on the same page. So that was a very important step. As Beatrice mentioned, we also anticipated this to be short term, but it went longer than what we all anticipated. But overall, as she mentioned, heavy resources, ongoing training, ongoing partnerships, support not only to the families and students, but the instructional staff, and even our what are they? I'm sorry. Food providers, our greeters, everybody that was working with our children, our families, they also got the services as well as a whole. So we made sure that we covered them as well. That's it.
Fantastic, thank you. And I just want to do a quick time check. We have one more question that will be posed to all 3 of our panelists. And we want to conclude roughly in about 10 minutes or so. This way we have enough time to open it up to questions to the folks that are in attendance. So again, my last question for each of you is, what can parents and community agencies serving children and families do to best prepare our children to return back to on-school campuses or on-school education?
I think one of the things that is going to be pivotal is that communication, for parents to let us know, hey, they're really scared to come back, or we can only get them to keep the mask on for 10 minutes. Or my older children are going through this, and so there's an impact. I think that more than anything is going to make all the difference as far as children coming back and being successful, or coming back and experiencing fear and anxiety that's not addressed. So that open communication with parents, caregivers, staff with each other, and our staff with the clinicians is going to be pivotal for us for preparing families to return to school.
To add to what Arlene mentioned, also is a comfort level for our instructional staff. I think our instructional staff had lots of fear, anxiety, so many pent up emotions. But we saw that once they returned, it was smooth sailing after that. They were comfortable. They managed their technology back to the classroom, the comfort level. So you could see the comfort, the ability to be just comfortable within themselves, within their own skin on a day-to-day operation. So that was great to see from our staff.
And if I could just add, going back to my experience as an administrator at an alternative in an alternative ed setting where the school is essentially the community hub. You have parents connecting and coming in to really have their connections to community partners and resources available in the community. Going back to what Arlene shared is really that communication piece. Parents and community partners connect to the schools that your children attend and really ask the questions, ask all the questions that you want answers to. And when there aren't any answers, continue the partnership and perhaps be part of the solution. And so it's really in bringing the community together and really engaging in the continued education of our students, because we all succeed when our students succeed. And more than ever, again, kind of going back to the beginning of this experience, first it was about the students, but now it's all about all of us. So how do we have the strength and the resiliency to, when we're not well enough, how do we still put up a front for our students and say, you can do this, we will get through this together? And so it's really just embracing the difficult experience that we are transitioning out of and into a new way of life, whatever that's going to be. And so there's the true answer for this is for parents and community partners alike to communicate with teachers, with counselors, with administrators, stay connected and be a part of the solution, as they have been through this pandemic, because we probably have seen the most parent engagement through the past year because of technology, the availability of technology. And so connections, simple.
Thank you. It's very apparent that there's a lot of new things that we're all experiencing, lots of new emotions that maybe in the past we would kind of brush under the rug, but now we have to deal with them. And so thank you again for being part of our panel. We're gonna, on behalf of the IECHI, I'd like to thank you for being part of the panel. And I would like to take this opportunity to open it up to any questions that our guests have for our experts.
If you'd like to, I don't really see any questions in the chat. If you'd like to use the raise hand feature, we can do it like that. There were a couple of comments in the chat. In particular, Dr. Matney, you had a few comments, and Nancy Weir had some comments. If you'd like to do those verbally, interactively, we could do that. Dr. Matney, do you want to make your comments to the group, or?
Sure. Hi, Dr. Glenn Matney, pediatrician in private practice in Victorville. And my comment was pointing out the actual case fatality rate of children 0 to 5 in the state of California, per data on the California Department of Health website, is 2 fatalities out of 16 some odd thousand. That's a case fatality rate of 0.002%. And there's 17 deaths in children 5 to 17, and that's a case fatality rate of 0.004%. So the lockdowns are still ongoing. They're barely getting back The worst affected, of course, have been the young. And my other comment was about the whole concept of first five and the first 5 critical years of brain and social development. And we've just peeled off and crumpled up and thrown in the wastebasket about 25% of that. Head Starts have been closed. Autistic children in my medical practice are expected to go on Zoom. So if you think of an autistic child sitting in front of the computer and getting ABA therapy or speech therapy, OT cannot be done over a computer. Physical therapy cannot be done over a computer. And they're slowly starting some of this up again. But I practice in a very poor area, a very racially diverse area. And there's a lot of talk about race, but this is a problem of class. And the Zoom class people, they have a home and they've got computers. And I had a Black grandmother in my practice. She's got 8 children in her home. This is like a 2-bedroom apartment. Daddy doesn't have his spare bedroom for an office, and mommy with hers, and the kids in a room. The best cure for racism, if we want to go on about that, is education. And this is just lost time that cannot be recovered. And there's a lot of talk about mistakes were made and what we knew then. Academy Pediatrics has been calling for in-person return to school since June of last year, almost a year ago now. And, people are very upset and unhappy about this. All political parties, all races, all walks of life. And you can see the data with your own eyes. It hasn't been justified scientifically and medically. The outsized fear of young, healthy people, and I'll include teachers in that, and even teachers in my own family that are young, healthy adults, to going back to school is really something else. The kids should be together. And I see depressed, suicidal ideation teenagers 2 a day in my office, every single day at least. And the data in Las Vegas on teenage suicides, there was 12, I think, already last year. I don't see any body counts from California or from the county on teenage suicide. But when it's all summed up, I will put down a bet with anyone who wants to take it that's going to be more than 17. They're going to be dead from suicide compared to the 17 that sadly, and it's very sadly, of course, died from this disease. So we need to gain some perspective. And the mistakes were made, but not by me, is the refrain of everyone with that. And no single raindrop thinks they're the cause of the flood, but we're not all in this together. Those of us that are getting a full paycheck, staying at home, are not in it with poor people in 1 and 2 bedroom apartments with a bunch of small kids and with special needs. No, let's just stop saying that. We're not all in this together. There's a lot of people that are really being screwed here, and unnecessarily, in my opinion.
Thank you for your comments. Is there anyone who'd like to respond to that or add to it or?
I know that for PSD, we serve that population. Our target population is children living under the federal poverty line. And the fact of the matter is that we don't make the decision for children in a vacuum. Oftentimes, our families are living in multifamily housing situations, have limited access to health care. So when we talk about families getting sick, we're not just talking about young, healthy adults. We're talking about grandparents, co-living situations, extended. So those 8, 9, 12 people living in a single household, it's not all young children. And another fact is many of our teachers come from those communities. So they share those concerns, and they oftentimes share space with those families. They live in those communities. Their housing is in the communities that we pull from. So while we can look back and kind of second guess, I will say that, and I'll speak for all of us here, if you allow me, that we all made the best decisions with the information that we had at the time. And one of the reasons that we focused on parent education, parents as teachers, parents as advocates for their children, is because we recognize that the first 5 years are critical. And so we want parents to be able to identify, to support their families. And as someone raising a child living with autism, I know that those Zoom meetings are tricky. And I know that it's impossible to do OT. And so one of the things that I did personally was make sure that I attended every session I could to learn strategies to work with my baby, to learn strategies, you know, to fill in some of the blanks when there was no way that people were going to come in and access my home. So
you can't extrapolate your personal experience as an educated professional to underclass parent, barely unemployed themselves, to learn these skills. And plus, possibly they're trying to hold down a minimum wage job themselves. And now they can't. And the data is there for all that want to look at it. It's not a dangerous illness for children, thank God. But cooping everyone up together in small houses and apartments was probably not the greatest idea. It's just a good way to ensure that everyone catches it together. And yes, we didn't know everything at first, but this has been a year now that Academy Pediatrics has been calling for in-person school. And that was in June of 2020. It's now May of 2021. And, there's still a lot of, mistakes were made, but, it's time to get on with it. We're not going to get a do-over. Those kids don't get a do-over. There's no do-over. It's under the bridge water now. And so
I will say that we did as much as we could as soon as we could. We wanted kids in class too. No one wanted kids to be at home. And when there was a necessity for them to be at home, because of stay-at-home orders or because of other things, we tried to equip parents the best we could.
Well, I don't see anyone going around saying, we should have done differently. We could have done differently. That was a mistake. This was a mistake. It's all, everything we did was perfect up until now, and it's even going to get better. I just don't see it that way, and a lot of people don't.
Absolutely. I understand that.
Okay. So, Kelley Maxwell, did you have something you wanted to add? I'm sorry, for those of you looking for the raise hand feature, if you look at the bottom of your dashboard on the far right, there's a little icon, a smiley face, and it says reactions underneath. If you click on that, a bunch of little icons will come up, an X and a check mark, and there should be a little thing that says raise hand. But don't worry about that. Kelley Maxwell, do you have something? There you are, Kelley. Hi, did you want to add something? You go ahead and speak up right now.
So thank you so much for putting this together. We really appreciate it. I am a middle school principal in the High Desert in Hesperia Unified School District. And we have a huge focus right now on mental health and SEL. And middle school kids are an interesting breed. So you either love them or you hate them, and I absolutely love them because I've been working with them for over 20 years. And so we are in the process of putting together a wellness center here at Cedar Middle School. It'll be the first one in our district, and I know there's a few other schools in the district that are working on putting those together, and we're working with partnerships in the community and so forth. I just feel like there's such a fine line with middle school kids. And a lot of this was brought on. I went to a workshop, I think it was 2 years ago down in County of San Bernardino, and they were talking about their school having a wellness center. I'm like, that would be great. And then of course, the COVID, the pandemic, brought it even closer to the forefront of our, of this happening for us. And then we did have, unfortunately, a couple tragedies here last year with students who took their own lives. And so it's just been something that we knew we had to do. And so where is that balance of making sure that you're getting that information out to your kids and to your families. Mental health awareness shouldn't have this negative stigma. But we don't want, there's just got to be that fine line. And like I said, I think if it was high school, it'd be a little bit different conversation, but with middle school, help me understand where that line might be.
There's an interesting thing on the Today Show this morning. I guess there's a push on TikTok, and I'm not that knowledgeable about TikTok. I'm way past that age demographic, believe me. But I guess there's an effort being made to reach out to kids to deal with mental health issues on TikTok. And there's a lot of kind of pop counseling going on, and it's trying to speak to kids on their own level about mental health. And apparently it's resonating with kids in I think it's middle and high school. So I don't know, maybe that's kind of one way to approach it, is because it's getting kids' attention. But
Well,
I just
we've been talking about the multi-tier support systems that we're starting to put in place, not just school, but district-wide. And it really is about that first tier, that prevention, because once you get into that tier 2, you're trying to keep your head above water at that point. So really trying to let kids know it's okay to talk about mental health, and teaching them the strategies as we've talked about today. When we came back from winter break, we've been pushing out some lessons to our students, and they have one teacher that is mentoring them throughout the rest of the year, and teaching them, like I said, those coping skills and stuff. So we're super excited. But again, we are going to be looking for those partnerships out in our community. So I do see somebody, Alex sent me a direct message. So thank you, Alex. I'll be reaching out to you, and we'll keep our fingers crossed for our middle school kids.
Kelley, this is Veronica. Just a real quick thing. Do you all participate in directing change as a middle school?
No.
Okay, so I'll send you information about that. If you can maybe you could put your contact in the chat. And so that is just a way that a lot of our school districts have been getting involved in Mental Health Month. And it allows them to create 60-second PSAs. They use their iPhones or they use Zoom or whatever. And then it's judged locally between us here in the IE for Riverside and San Bernardino. And there's a big award ceremony that happens at Sacramento. And in San Bernardino County, we've had a lot of our kids who've been super successful, but it addresses what they see mental health as, and addiction and suicide. And from what they've said, it's super empowering because it's them talking to them, right? Rather than us as parents or as, adults talking down to them. So it's been super powerful for kids. It's a great way, I think, to introduce something, maybe to help kick off your wellness centers. But I will make sure I send you information and have our public information officer send you more information about activities that you all might be able to participate.
Perfect. Awesome. Thank you. I'll put my contact information in the chat.
Kelley, thanks for all the work you're doing. It sounds like you're obviously super engaged and you love the kids, so I'm sure the kids love you too. I mean, thanks for putting your all into it. It's really appreciated. I don't see any raised hands unless I'm missing it. I don't really see any questions, but I do see Arlene Hofer and Robin Ferguson. You guys are making some really good comments online, and Kitasha Barber. Do you guys want to say anything? Make any comments? Because you guys are making some good comments on the chat. Do you guys want to say anything? Robin or Arlene or Kitasha?
This is Robin. I work with the Early Start program at Inland Regional Center. So I was just wanted to say that, yes, I do know that the Zoom meetings do not work for everybody, especially our little ones. But we did see that there are many, many, many children who were still able to have physical therapy, occupational therapy, speech therapy, and their early intervention programs via Zoom this last year. And it did work. The physical therapy, I know it's different than somebody coming in the home and holding your child, but we were teaching the families families to do the positions and the moves. And, at least it was not like they went a whole year without having any type of services. So, again, optimal is we can't wait to get back into the homes, but, for safety reasons, we were happy that we were able to continue those services this whole year with our children. So, we do see the success in it. We're hoping to continue that for some of our outlying areas in San Bernardino and Riverside County in the future, because there were many families that therapists couldn't even get to their homes, and now they can at least have access to this type of services. So, yep, that was just my my 2 cents about that area. Thank you so much.
We really appreciate that. Thank you very much. Awesome. All right. Well, I don't.
I showed Dr. Matney's. Dr. Matney has his hand raised as well.
Oh, it's hiding up in those little.
Yeah.
I didn't want to chime in again right away.
Sorry, I missed it.
I want to cross comment on just the last statement. I know they're trying, but that hasn't been my experience in my own pediatric practice, where I meet autistic children and autistic parents of autism every single day, and it hasn't been a bowl of cherries. The comment I wanted to make about addiction and alcoholism, in addition to pediatrics, my wife and I run a small drug and alcohol treatment center here in Victorville as well. And we applied for grants with IEHP just before the pandemic, and that got pulled back from the state level. We put a big grant proposal in for that to combine mental health with primary care, and that got yanked, and I haven't seen it come back again. And the other thing that happened is the California Hub and Spoke program was a federally funded state-run program to give opiate treatment to uninsured and underinsured population that we participated in through our center here, and we were going to participate again. And thanks to the change and also the inability, for reasons that we don't understand, for the County Department of Behavioral Health to put us on as a vendor, we weren't renewed for that despite our protestations. So now in the high desert, we were advised from the state level, well, you can send people by Uber to Upland and to Riverside that ask for treatment. We have a list of about 125 people just since the 1st of September that would have qualified for drug and alcohol treatment, for medication-assisted treatment for opiate use disorder, alcohol use disorder, stimulant use disorder. That we were just happily going right along treating them, and the rug was pulled out. So there's a lot of talk about everything that we're doing together, but we're actually here in the trenches supplying these services, and the rug was completely pulled out, and it doesn't seem like it's coming back. And so now we're just moving on, but that was a real travesty, and that happened. And so, yes, there are a lot of deaths going to happen and are happening from alcoholism, drug addiction, opiate overdose, and on and on and on, that are going to carry on long after the COVID is subsided. So.
Okay. All right. Well, listen, it looks like we're at the end of our session today. I do want to say something. I want to say that it's been really hard for the kids, these students, getting whiplash from being told different things to do. Schools being open and closed, and Zoom and in person, and sometimes hybrid models. I know that's been really hard, but it's been really hard for not only the parents, but the teachers and the educators. My heart really goes out to you guys, and it's been really tough for you guys. You've been having to make a lot of adjustments, and I mean, talk about stress, having to make these constant adjustments, not just in policy, but in your day-to-day lives. And so we really appreciate all of the continual changes and and edits to, you know, hourly to your lives that you've been making and all the personal sacrifices. So thank you all. So your mental health has suffered too. So thank you all. And I say that to our panelists and to our speakers today. So so with that, I will say officially thank you to our speakers. Dr. Veronica Kelley from Department of Behavioral Health. That was a fantastic presentation and a really great update. And you are a magnificent partner to all of us. And we really, really appreciate you and all you do. So we know your heart is in this and we thank you. I also want to thank Arlene, Molina, and I want to thank Felix, Perez, and I want to thank Beatrice Blake. You guys were magnificent and you certainly took those questions and handled them well. Boy, you covered every aspect of that. So thank you very much for that. You guys rock. Alex Bravo with Molina, thank you very much for facilitating that panel. That was magnificent. And also, as always, I want to shout out to Victoria Stephan, who we didn't hear from you today, Victoria. You kept yourself on mute there, lady. So give us a wave so we can all see you. And thank you. Victoria's our consultant to the IHI and basically runs the show here. Don't mean to sell our board short, but Victoria keeps that engine running, as I always say. So thank you for that. If anyone would like to get more involved in our coalition, I really encourage you to do that. We also have an advocacy task force. We have a rural healthcare task force, that all of which are very active. We do have a board of directors and advisory council. We do have our website, which I mentioned at the beginning of this, the IHI.org. And please go ahead and like our Facebook page. It's a great way through which we communicate upcoming events and upcoming announcements and important things that we have to share with the community. So if you go to Facebook and just, you know, hit search for IHI, I would really encourage you to do that. So, all right, everyone, thank you very, very much once again for joining us and being a part of our ongoing health education forums, which are held quarterly. Victoria, do we know the date yet for our next one, or the month at least? You're on mute, Victoria.
I'm now not on mute. It'll be the next health education forum will be in September.
Okay.
I believe because of the Labor Day weekend, it'll probably be the second Tuesday instead of the first Tuesday in September, and information will going out. I think it was also on the program if you saw that listed today, but September, put down September, I think it's 14th, and we'll see you all then.
All right, great, everyone. So we'll be announcing that topic. And as I say, we will be announcing that not only through email, but on our Facebook page. So we'll keep you all posted. And thanks, we appreciate you all. We appreciate all the work you do. And thanks for working together and being great partners. So thank you, speakers. Thank you all. See you guys soon. Have a great week.
Thank you.